some great ideas. So I was given this intriguing title and asked to focus a little bit on what's new in robotics and implant fixation technology and outpatient surgery, some of which have already been covered. So maybe I'll go over them fairly quickly. I want to stress, as I always do, my disclosures. In particular here, I am going to talk about robotics, and I work with Stryker, and I'm going to talk about their device. So I think you should be aware of that. Our partnership with industry creates a lot of challenges in terms of how we interpret and guide innovation. So bear that in mind. So we've just heard a little bit about how we look at things in terms of long-term outcome. And the reality is we've done incredibly well as a community. We've come a long way from where we started 30 or 40 years ago, both in the hip and the knee. But what the registries don't tell us is that things are changing, and we need to take that into account. That's one of the confounders that Martin Porter mentioned. And we definitely are seeing change in arthroplasty that we need to be alive to and deal with as we move forward. The first one is that expectations continue to rise. Our patients no longer just want pain relief, they expect to function well, they expect to be normal. They also need things that last for longer, because our young patients who increasingly need arthroplasty live very long lives. And even our old patients, in whom we thought we could just about get away with doing whatever we wanted, now are extremely active in many circumstances, and therefore need something that's not just durable, but is also functional. And we also face the challenge, certainly in my part of the world, that they're all getting fatter, which both makes the surgery more difficult and the outcomes compromised. And there are other challenges I'm not necessarily going to address, but we all know our workload is increasing dramatically, yet surgical training is becoming more difficult. And that's something that we're going to have to address, perhaps with enhanced technologies. That's why I mention it. And costs are also increasing, and they are going to be important as more and more patients get orthopedic surgery. We know that as we do more arthroplasty, we're doing it on younger and younger patients. And I'm really just stressing this because the young are a big problem. These are registry slides. They're very valuable registry slides. And what they show you is that there is a higher failure rate in the young. And so that group is more challenging. And so we cannot generalize from what we do in the average patient to the young patient. And yet there are many of those in increasing droves that are coming our way. Bear in mind that not all modern solutions are bulletproof. This is probably the most popular cementless stem worldwide, and yet I revise at least half a dozen of them every year. So I think you have to be very careful at what you look at and who you look at it for and in whose hands, because the data that you use to justify anything that you do has to be very carefully analyzed. So the modern total joint replacement patient has many, many demands, and we have to meet those demands. And so I want to go through some of the things that we need to look at to achieve that. And I think we've learned a great deal. I can't cover everything. In the last decade, I think we started to focus on functionality. Durability was the goal before. I think we've recognized, particularly in the knee, that there's a proportion of patients that are unhappy. Every surgeon denies that that is the case in their practice. The reality is, if you look at the data carefully enough, if you follow up the patients carefully enough, it is true. It's even true more than you think in the hip, or they're not as bad as in the knee. We've heard a lot on this course that unis do better than they initially thought, and I'm going to talk a bit more about that. I'll mention hip resurfacings and see whether they can come again and have yet another life. We've heard about dual mobility and its future. We've got better polyethylene, and component fixation is interesting. We had a great debate about it. I still think that debate is live in the knee, where cementless fixation is having a dramatic rise in the United States. Robotics are back in a variety of form. I'll talk about those, and we've heard a lot about enhanced recovery. When implants fail, there are generally three reasons. It's either poor design or manufacture, it's biological failure, or it's surgical failure. And it's the latter that we really should focus on, because that's very much under our control. The key is the surgeon. And I'm going to talk about surgical technique, but actually it's surgical decision-making that we don't spend long enough talking about. The surgeon can make that decision with the patient as to what surgery they do, when they do it, and how they do it. And that's really key. And it's the surgeon's role to manage the patient's expectations and understand their psychology. I'm not going to dwell much on that, but actually in orthopedics, if we're going to go anywhere, that is a really wise thing to look at, because managing expectations is key. Of course, the surgeon chooses the implant and they choose the technique. Now, we know that some surgeons are great, others are less great, but we don't all have a perfect day every day. And the reality is failure, as in all these cases here, is often a technical mistake. And so we need to try and reduce that. And that's where I think robotics comes in. It's the move from craftsmanship to systematic planning and execution. We've been down this road before, but it was a question of when we would get down this road in a way that would work for us. And we can follow other industries. People talk about the airline industry, but actually all industries go through from craft to rules to standardized procedures to automation and ultimately to computer integration. The easy analogy is what pilots are doing. We're going there in surgery gradually. We've got checklists. We're using computers. Now robotics are coming in. That journey is inexorable. It's really just a question of us understanding it, using it effectively, and making it cost effective. I'll go back to unis because I think that's a huge opportunity. I was really pleased to see Herman Pandit and other wonderful proponents of unis on this course. The reality is, in my practice, my unis are without doubt my best arthroplasties. They are absolutely superb, and they have better function, better proprioception, better range. They can do more activities, and it's a lower complication, lower morbidity, lower mortality procedure. But those of you, and in good hands, they work extremely well. But those of you who looked at Martin Porter's benchmarking for the knee would have seen on that top right-hand side of that slide that the worst knee replacements in terms of registries are unis. They have a high revision rate. So when you benchmark them that way, and when you just look at revision, they do badly. So we need to do something about unis. It's a great operation if it works, and so we need to make it work. And that's where enhanced technology will come in. In my hand, it's with robotics. In other people's hands, it may be different, but certainly our data so far would suggest, and you can find this in the Bone and Joint Journal a couple of years ago, less pain, less opiate utilization, less need for physiotherapy and medical review, and a better recovery. In reality, we're just finishing a prospective randomized study to look at this in more detail, but the signal seems to be similar. The really interesting thing is when you start looking at implant positioning, it is significantly better from the first case. So once you've got access to this technology, you can hit the target straight away from the first case onwards. There may be extra time involved initially, but the reality is you can hit where you want to hit straight away. And the signal we've seen isn't just our signal. Markblind has shown that, and now to up to 5 years follow-up, these cases are more accurately inserted. They get the positioning that they want, and revision rates are low. So there is an advantage here, potentially, that we can make uni accessible to more people. Andy Pearl's group has now followed them up. This is the published data out to more than 5 years. The 10-year data is under review, and they really have done very, very well. In terms of aseptic failure, the Australian registry would suggest that this is the way forward. So I think the enhanced technology will help us to do more unis. They may eventually help us to do ACL preserving or multi-compartmental arthroplasty, and eventually to develop implants that are just inserted that way. Because you've got to remember, our current implants are done in a way that's guided for manual guidance by surgeons. I talked about total knee robotic arm assistance 2 days ago, so I won't dwell on the technique in detail, but we've shown that there is less soft tissue damage, that we can predict and size our implants better into where they need to be from that point of view, and that people can learn this very, very quickly. So the literature is beginning to show evidence for this, and just like the uni, you can hit the target you want to hit very quickly. So what I wanted to share with you is a study that's just come out last week in the Bone and Joint Journal to really try and strengthen that evidence base. So this is a pilot prospective randomized study, because at the end of the day, we have to create evidence for the use of these technologies and justify their cost, comparing jig-based versus robotic arm-assisted total knee arthroplasty with the same target in mind. So the patients were randomized, they were done in the same center by the same surgical team, and we looked at all the metrics you would imagine, such as soft tissue and bone damage, imaging, and we also looked at the inflammatory response. I mentioned the MASD soft tissue damage score, and we saw much less soft tissue damage using the robotic arm. That's partly the saw blade being controlled and having boundaries. It's partly perhaps that we release the soft tissue somewhat less. We also see less bony trauma, which may be one way of eventually doing less, using cementless knee replacements rather than relying on cement. This is a very busy slide. It just shows you the number of inflammatory markers we looked at. The key thing is that if you look in the first couple of days, you'll see a decrease in interleukin-1 and TNF. So we're seeing a lower inflammatory response. Same surgical team, randomized patients, same technique, same implants, other than we're using the robot in one group and we're not using Mako in the other group. So we think that's probably multifactorial: less soft tissue injury, less bony trauma, possibly less metallic debris from the manual blade and cutting blocks, and we're not intramedullary referencing. So it's an interesting signal. It's certainly something that we need to study further for the future. Same in the hip. We're getting to the stage where we've been using this for a couple of years. Again, we've published our data, so I'm not going to dwell on it for now. And the randomized studies are recruiting. I'm pleased to tell you from a UK perspective, we strongly believe in getting evidence. So beyond the 4 randomized studies already running in London, there are the RACER studies, the knee RACER studies funded by NIHR as a national study for robotic knee replacement comparing with manual, and the hip study has just been funded too. So we will really come back to you over the next few years with some level 1 answers, but the signal so far seems very positive. We had some great discussion at this meeting about the spinopelvic relationship. That's the real challenge in the hip at the moment that everybody's worried about. But in reality, if someone gives you a technology where you can get center of rotation, combined version, length and offset right, you should bite their arm off, because that's a long way to getting the hip in the right place for that patient. And the new technology now allows you to adjust for spinopelvic parameters and also to measure impingement intraoperatively. So nothing published on this yet. It's something you need to watch with interest though, because it is resolving most of the problems we are worried about. And as I said, we've got some RCTs up and running, so we'll be able to get you some data at some stage soon. Once we have that data, it'll really be interesting, because we'll be able to do cost effectiveness studies and ultimately to integrate that data with AI and machine learning to help predict, based on a CT scan and an alignment X-ray, what that patient will need in future. What about resurfacing? Many people have abandoned resurfacing. We're still interested in it because we really saw a signal in terms of function for our resurfacing patients out to 10 years from an old study that I did, in fact, started almost 20 years ago. There was definitely some advantage to my mind in terms of those patients' activities. Again, it's all about understanding where the spine, the pelvis are in getting the right position for the implants. So one day, I think resurfacing will have another life. It may be robotic arm assisted, it may be ceramic, but do not dismiss resurfacing out of hand at this stage. What else is changing? I was asked to mention cementless fixation. I'm a great believer in osseointegration, but the trouble is, again here, like everything else, there's lots of confounding in terms of designs, in terms of what metals, in terms of how things are both created and implanted. But the reality is, in the hip, cementless implants pretty much work very well now. The problem was with the bearing, and that's been resolved. The knee is changing rapidly. Right now in the United States, cementless knees are rising very dramatically, and you can understand why. Easy surgery, none of the issues that you have with cement, osseointegration, and we have a problem, as I mentioned at the beginning, with young patients that we need to resolve. There is potentially a cost issue, but that's country by country. The training issue is one that people worry about, but if you've got enhanced technology, you may be able to avoid that. And all the previous literature on complications and early failures with cementless implants don't seem to be borne out by the more recent work, particularly Robert Barrett's randomized studies. Again, level 1 data suggesting that this technology can be made to work quite easily. The last thing I was asked to talk about was outpatient arthroplasty. You've heard some great presentations on that already, particularly today. I think the reality is that's something that is now with us. In the UK, there is a very big central drive and leadership in the NHS, and there's a group that's now setting percentages of expectation as we recover from COVID for how many patients should have day case arthroplasty. So we really are sort of starting to move in that direction. Not all the drivers for this are aimed at patient benefit. We've heard about the pros and cons in the United States, but now with COVID, we recognize that we need patients in hospital for less and less time. I don't think you should be scared of it. This is just the natural extension of fast track and the same principles. You've heard them already today. Diminish blood loss, reduce pain, and avoid opiates and all their side effects. And it's basically that transition that the Mayo Group described from a sick patient to a well patient model. You know, if you screen them right, prepare them, that's easy. We saw, just by adopting those basic principles, a dramatic reduction in length of stay without any complications and with highly satisfied patients. So the extension of fast track was always going to be outpatient arthroplasty. It just needs you to be careful. Select the right patients first, optimize them, educate them and communicate with them, get them moving straight away, reduce blood loss, and get a good post-operative package. It's not for everyone. We think it'll work in our practice for unis in 50%, for hips in about 25%, and less so in total knees. We tend to do them early on the list, get the patients who are keen, and it seems to be to us more likely now with thin males who are under 75. We're prepared. We do them in the main hospital. We don't have the financial pressures of running an ASC in the UK. So even if they stay overnight, there's still an advantage over where we were a couple of years ago. So no matter how badly you feel about it, it's something you need to think about. We absolutely should be doing this, but it's not for everybody. And you've got to think why you're doing it and to what patients very carefully. So when I was a trainee, which admittedly was a long time ago, one of my mentors, George Bentley, told me that everything had been resolved in joint arthroplasty and I should be going into something else. I fear that he was wrong, because we still have plenty of challenges that we need to resolve. I don't pretend to have the answer for you, but I think the future will be based on the surgeon educating the patient better and selecting the patient at the right time, on less invasive surgery, particularly using technology. I think we're going to get much better implants and bearings, and that's where the challenge of how we introduce them and how we manage the registries and the costs are going to come in. I think robots are here to stay. We're going to have optimized surgical execution. We can all be made better by the use of technology. And eventually, ultimately, I hope in my lifetime, we will be able to personalize, because right now, everyone does what they do well. Ultimately, we should do what works well for each individual patient. So thank you for inviting me. I'm sorry once again not to be with you in person. I think that's the way the ideal meeting runs. And I hope we will have the opportunity to all be together, all vaccinated and all well